Welcome to this e-course on diagnosis and care of children living with HIV infection. This module contains audio. Please adjust your speaker settings as necessary. You may activate the audio presentation of each slide by clicking on the audio icon, located in the bottom left or bottom right corner on each slide. To advance from one slide to the next, click on the right arrow if in slideshow mode. Alternatively, you may be able to use the page down function or simply to click open the desired slide. This training module is intended for individuals providing HIV testing and care service to children, defined by World Health Organization as those less than 10 years of age. After completing this module, you will be able to describe which infants are at risk of acquiring HIV at birth and what ARV prophylaxis they should receive. Understand how HIV is diagnosed in children. Describe what antiretroviral therapy to start in children. Define first-line regimen failure in children and know how to switch to one of the second-line regimen choices recommended by WHO. Describe infant feeding options in the context of HIV transmission risk. You will also understand indications for cotrimoxazole prophylaxis in HIV-exposed infants and the principles of differentiated care as they apply to children. The module summarizes the recommendations made by the World Health Organization in the 2016 Guidelines on the Use of Antiretroviral Drugs for Treating and Preventing HIV Infection. It also takes into account updated recommendations on first-line and second-line antiretroviral regimens and incorporates recent recommendations on early infant diagnosis of HIV. The epidemiologic data on pediatric HIV are sourced from the UNAIDS 2018 data report. The source of the information in the section on differentiated care for children is a policy brief developed by the Child Survival Working Group in partnership with the International AIDS Society, United Nations Children's Fund, and the World Health Organization. Let us now go over some of the epidemiologic data and the WHO recommendations on treatment of HIV in children. Despite notable progress in the global HIV response, an estimated 110,000 children below 15 years of age died in 2017 from AIDS-related causes. In this same year, there were 180,000 new HIV infections among children below 15 years, equivalent to over 15,000 children newly infected with HIV every month. An estimated 3 million children and adolescents worldwide were living with HIV in 2017. Of these, nearly 9 in 10 live in sub-Saharan Africa, and yet children are being left behind. Despite increased access to technologies for early infant diagnosis of HIV, in 2017, only 51% of HIV-exposed infants received an early infant diagnosis test within the first 2 months of life. Despite the widespread availability of several child-friendly fixed-dose combinations of antiretroviral medicines, ART coverage among children lags significantly behind that of adults. What is more, countries continue using suboptimal HIV medicines for children, which leads to high rates of treatment failure and antiretroviral drug resistance in children. In December 2018, a high-level dialogue on pediatric HIV was convened in the Vatican City. The World Health Organization and partners issued a strong call to accelerate children's access to effective HIV diagnostics and medicines to bring an end to pediatric AIDS. WHO recommends that treatment for children should be implemented at all levels of the health system, including the primary care level, and by all ART service providers rather than by pediatric specialists alone. While the predominant mode of HIV acquisition is perinatal exposure to HIV, very rare modes of transmission include sexual abuse, receipt of contaminated blood products, and needle stick injury with contaminated needles. Let us begin by summarizing the key information from WHO on HIV diagnosis in infants and children. Because mortality in the first year of life is so high among untreated HIV-infected infants, early HIV testing, prompt return of results, and rapid initiation of treatment are essential. HIV infection can be definitively confirmed in children less than 18 months of age only with virological testing using nucleic acid testing technologies, or NAT. This is because maternal HIV antibody may persist in the child up to 18 months of age, preventing the use of serological testing to diagnose HIV infection. WHO recommends point-of-care early infant diagnosis. When programs use point-of-care testing, the proportion of HIV-positive infants who initiate antiretroviral therapy within 60 days of sample collection is 90%, compared to 13% with traditional centralized EID testing. WHO recommends that all HIV-exposed infants should have HIV virological testing at 4 to 6 weeks of age, or at the earliest opportunity thereafter. Further, WHO recommends that the addition of nucleic acid testing at birth to existing early infant diagnosis testing approaches be considered. Infants with HIV detectable by NAT at birth are likely infected in utero. In the absence of treatment, these infants will progress to disease rapidly and classically have a very high risk of dying within the first few months of life. Infants who are infected at or around delivery may not have HIV virus detectable by NAT for several days to weeks. WHO reminds national programs to retest all those infants who are diagnosed HIV positive with a second specimen and a second operator using the same testing strategy and algorithm before enrolling the child in care and initiating ART. In infants with an initial positive virological test result, WHO strongly recommends that ART be started without delay and at the same time as a second specimen is collected to confirm the initial positive result. Immediate initiation of ART saves children's lives and should not be delayed while waiting for the results of the confirmatory test. This slide illustrates a standard operating procedure to follow for early infant diagnosis testing. Of note, all indeterminate test results should be repeated on the same specimen, if and when available. If the same specimen cannot be repeat tested, then a new specimen should be requested and tested as quickly as possible. For specimens with two indeterminate test results, a new specimen should be requested. For infants repeatedly testing indeterminate, it is suggested that a team of experts review clinical and test information to determine the best follow-up care. Testing throughout the exposure period. The complexity of early infant diagnosis testing is growing. Early infant diagnosis can no longer be a one-test process, but now requires additional testing over the duration of exposure. The dynamics of mother-to-child transmission have now shifted towards increased transmission during the postnatal period. About half the children acquiring HIV get it during breastfeeding. Programs should therefore strengthen the early infant diagnosis cascade to ensure that all HIV-exposed infants are tested throughout the entire exposure period. WHO guidelines recommend that the final diagnosis of HIV-exposed infants be conducted 3 months after breastfeeding ends, or at 18 months of age, whichever is later. Confirmatory testing of all positive test results. An analysis in EID programs in South Africa showed that in settings with mother-to-child transmission rates similar to those of South Africa, more than 10% of infants who initiated treatment may potentially have false positive diagnoses. All positive test results should therefore be confirmed using a new sample at the time the treatment is initiated or before. Any nucleic acid-based assay can be used for confirmatory testing of children younger than 18 months, and programs should consider using whichever platform is available, including point-of-care technologies. If HIV is suspected, WHO recommends that infants and children below 18 months of age with unknown HIV exposure status who have signs or symptoms suggestive of HIV infection should undergo HIV serological testing to ascertain HIV exposure status. If the serological test is reactive, it must be confirmed with a virologic test at this age. Children 18 months of age or older with suspected HIV infection or HIV exposure should have HIV serological testing performed according to the standard algorithm used in adults. As voluntary counseling and testing services are poorly utilized in pediatric populations, provider-initiated testing is essential to improve identification of children with HIV. In generalized epidemic settings, infants and children with unknown HIV status can be identified by proactive screening in postnatal clinics, immunization clinics, and pediatric outpatient and inpatient services. In postnatal clinics and immunization clinics where healthy infants present for normal care, if infants have unknown HIV exposure status, HIV testing should be sought in the mother, and then the infant should receive HIV testing if the mother is confirmed positive, or if the mother's status cannot be ascertained, for instance where the mother is deceased or unavailable. In health facility, outpatient and inpatient settings, infants and children with malnutrition, TB, other illness suspicious of HIV, or frequent illness should receive HIV testing appropriate for age, virologic testing if below 18 months of age, standard antibody testing if 18 months and older. In any setting, provider-initiated HIV testing and counseling should be considered for infants born to mothers in a high-risk population, and for infants at a higher risk of acquiring HIV, such as those born to HIV-positive mothers who did not receive prenatal care, did not receive antiretroviral therapy, did not receive antiretroviral therapy for the prevention of mother-to-child transmission, started antiretroviral therapy too late in pregnancy, or were not adherent to antiretroviral therapy and may not be virally suppressed. Informed consent is required from parent or guardian for HIV testing in children. Verbal consent is sufficient. A 2016 systematic review of 13 studies was conducted by WHO and reported on caregiver acceptance rates of pediatric HIV testing. While acceptance rates varied by location of testing as well as by region, the overall mean acceptance rate was high at 92.2%. Let us now consider the recommendations on ARV prophylaxis for HIV-exposed infants. Infants who are at a high risk of acquiring HIV should receive dual ARV prophylaxis with AZT twice daily, plus nevirapine once daily for the first 6 weeks of life, whether they are breastfed or formula-fed. High-risk infants are defined as those born to women with established HIV infection who have received less than 4 weeks of ART at the time of delivery, or born to women with established HIV infection who had a viral load greater than 1,000 copies per milliliter in the 4 weeks before delivery, assuming viral load measurement is available. Infants born to women with incident HIV infection during pregnancy or breastfeeding, or to women identified as HIV positive for the first time during the postpartum period, with or without a negative HIV test prenatally, are also high-risk infants. Breastfed infants who are at a high risk of acquiring HIV, including infants first identified as exposed to HIV during the postpartum period, should continue infant prophylaxis for an additional 6 weeks, to a total of 12 weeks of ARV prophylaxis, using either AZT twice daily plus nevirapine once daily, or once daily nevirapine alone. Infants of mothers who are receiving ART and are breastfeeding should receive 6 weeks of infant ARV prophylaxis with once daily nevirapine. If infants are receiving replacement feeding, they should be given 4 to 6 weeks of infant ARV prophylaxis with once daily nevirapine or twice daily AZT. The next section of this module will cover when and what antiretroviral therapy to start in children diagnosed as HIV infected. Infants and young children living with HIV have an exceptionally high risk of poor outcomes. Up to 52% of children born with HIV die before the age of 2 years in the absence of any intervention. As part of the Treat All policy, WHO recommends that ART be initiated in all children living with HIV, regardless of WHO clinical disease stage or CD4 count. Recommended first-line ART for children is abacavir plus 3-TC plus dolutegravir for age and weight groups with approved dolutegravir dosing. Alternative first-line regimens for children are abacavir plus 3-TC with either ritonavir-lopinavir or raltegravir. TAF or tenofovir alafenamide may be considered for age and weight groups with approved TAF dosing. Raltegravir can be used as an alternative regimen if ritonavir-lopinavir solid formulations are not available. Alternative regimens in special situations where other age-appropriate formulations are not available are listed in the last column of the table. Note that efavirenz should not be used in children younger than 3 years of age. For neonates, the preferred first-line regimen is AZT plus 3-TC plus raltegravir, with nevirapine and ritonavir-lopinavir as alternatives if raltegravir is not available. Neonates starting ART with a raltegravir-based regimen should transition to a lopinavir-ritonavir solid formulation as soon as possible. Lopinavir-ritonavir syrup or granules can be used if starting treatment after 2 weeks of age. The use of the integrase inhibitor class of drugs in children. Studies have evaluated the safety and efficacy of dolutegravir and raltegravir in children. Increasing levels of pre-treatment antiretroviral drug resistance to the NNRTI class of ARV drugs have been documented in low and middle-income countries. WHO recommends that countries with pre-treatment resistance to efavirenz or nevirapine at or above 10% should consider revising their preferred first line to an integrase inhibitor-based regimen. Dolutegravir has been approved for children older than 6 years, and raltegravir has now been approved for use from birth, providing additional options for neonates and children living with HIV. Consequently, new WHO guidelines regarding preferred first-line regimens for adults, adolescents, and children now include recommendations on dolutegravir and raltegravir. WHO recommends that above 6 years of age, dolutegravir 50 mg tablets can be used in children weighing at least 20 kilograms, and co-formulated tenofovir lamivudine dolutegravir or TLD can be used in children weighing at least 30 kilograms. Formulations of dolutegravir for children below 6 years of age in the form of dispersible tablets and recommended dosing for children weighing less than 20 kilograms are expected in 2020. For children for whom approved dosing of dolutegravir is not available, raltegravir is considered an effective integrase inhibitor and is approved for use among infants starting at birth. Raltegravir successfully reduces viral load among highly viremic infants and is safe and well tolerated among neonates and infants at high risk of infection. TB remains a common and important co-infection in HIV-positive patients. For infants and children younger than 3 years of age who develop TB while on an ART regimen containing either nevirapine or ritonavir-boosted lopinavir, abacavir plus 3-TC plus AZT is recommended as an option. Once TB therapy has been completed, this regimen should be stopped and the initial regimen should be restarted. The next topic that we will cover in this module is first-line failure and switching to second-line ART for children. To start with, we shall review recommendations on monitoring the response to ART and diagnosing treatment failure. Viral load testing is recommended as the preferred monitoring approach to diagnose and confirm treatment failure. Routine viral load monitoring can be carried out at 6 months, at 12 months, and then every 12 months thereafter if the child is stable on ART. In settings where routine viral load monitoring is available, CD4 cell count monitoring can be stopped in children who are stable on ART and virally suppressed. Virologic failure is defined as a persistently detectable viral load exceeding 1,000 copies per milliliter on 2 consecutive viral load measurements within a 3-month interval, having provided adherence support between measurements, and after at least 6 months of starting a new ART regimen. Dried blood spot specimens using venous or capillary whole blood can be used to determine viral load. A threshold of 1,000 copies per milliliter is recommended to determine virologic failure when using either dried blood samples or plasma samples. This table summarizes the sequencing options for first, second, and third line ART regimens for children. Please take a moment to review the table and the caveats included by WHO. Children failing a dolutegravir-based first-line regimen should receive 2 NRTIs plus either boosted atazanavir or boosted lopinavir as the preferred second line. Boosted atazanavir is recommended as an alternative to boosted lopinavir in children older than 3 months, but the limited availability of suitable formulations for children younger than 6 years, the lack of a fixed-dose formulation, and the need for separate administration of a ritonavir booster should be considered when choosing this regimen. In children for whom approved dolutegravir dosing is available, the preferred second-line regimen when failing either a boosted protease inhibitor or NNRTI first-line is dolutegravir in combination with an optimized NRTI backbone. In children for whom no approved dolutegravir dosing is available, who fail a PI-based first-line regimen, raltegravir plus 2 NRTIs remains the preferred second-line regimen. In those children for whom approved dolutegravir dosing is not available, who fail an NNRTI-based first-line, a boosted protease inhibitor plus 2 NRTIs is the preferred second-line regimen. Finally, for a third-line regimen, WHO recommends ritonavir boosted darunavir plus dolutegravir plus 1 to 2 NRTIs with the choice preferably guided by genotyping. Children younger than 3 years should not use darunavir/ritonavir. When dolutegravir in third-line ART follows previous use of an integrase inhibitor, dolutegravir must be administered twice daily. We will now turn to WHO recommendations on infant feeding in the context of HIV infection. WHO advises that national or subnational health authorities should decide whether health services will principally counsel and support mothers living with HIV to either breastfeed and receive ARV interventions or avoid all breastfeeding. In settings where national authorities have decided that maternal and child health services will principally promote and support breastfeeding and antiretroviral interventions as the strategy that will most likely give HIV-exposed infants the greatest chance of HIV-free survival, mothers should exclusively breastfeed their infants for the first 6 months of life, introducing appropriate complementary foods thereafter, and continue breastfeeding for the first 12 months of life. Breastfeeding should then stop only once a nutritionally adequate and safe diet without breast milk can be provided. All women living with HIV are eligible for initiation of ART regardless of the CD4 count. Finally, infants who are HIV infected will benefit from extended breastfeeding and should continue breastfeeding for as long as is feasible and desired. The next few slides will summarize WHO recommendations for the prevention of common co-infections that increase morbidity and mortality in pediatric HIV. Cotrimoxazole prophylaxis is recommended for infants, children, and adolescents with HIV, irrespective of clinical and immune conditions. In settings where malaria and/or severe bacterial infections are highly prevalent, cotrimoxazole prophylaxis should be continued until adulthood, irrespective of whether ART is provided. In settings with low prevalence for both malaria and bacterial infections, cotrimoxazole prophylaxis may be discontinued for children 5 years of age and older who are clinically stable and/or virally suppressed on ART for at least 6 months, and with a CD4 count greater than 350 cells per milliliter. Cotrimoxazole prophylaxis is recommended for HIV-exposed infants from 4 to 6 weeks of age. and should be continued until HIV infection has been excluded by an age-appropriate HIV test. Isoniazid preventive therapy, or IPT, in children. Children living with HIV who are more than 12 months of age, in whom the conclusion from symptom-based screening for TB is that they are unlikely to have active TB and who have no contact with a TB case, should receive 6 months of IPT, 10 mg per kilogram per day, as part of a comprehensive package of HIV prevention and care. Children living with HIV who are less than 12 months of age, who have contact with a TB case, and who have been evaluated for TB using diagnostic investigations should only receive 6 months of IPT if diagnostic evaluation shows no TB disease. All children living with HIV after successful completion of treatment for TB should receive IPT for an additional 6 months. Finally, in this module, let us discuss the principles of differentiated care as they apply to children. Children and adolescents living with HIV have a lifetime of antiretroviral therapy ahead of them. Differentiated service delivery is a client-centered approach, simplifying and adapting services to better meet the needs of people living with HIV while reducing burdens on the healthcare system. Differentiated ART delivery for clinically stable children is supported by global agencies, and a growing body of evidence highlights how differentiated ART delivery provides a significant opportunity to improve treatment adherence among children living with HIV. Children should not be excluded from differentiated ART delivery because of age. Clinically stable children can benefit from access to these models. Services should be designed to keep families together as much as possible, to simplify access and reduce costs of seeking care. After the age of 2 years, less intensive clinical follow-up is required for children, and ART refills and clinical consultations can safely be extended to 3 monthly for younger children, ages 2 to 5 years, and 6 monthly for older children. Strong engagement with peer providers and community platforms is a key facilitator of differentiated care. For children, it is also critical that parents and caregivers are supported in age-appropriate disclosure to the child. Caregiver support groups can facilitate this approach. In Zimbabwe, the Family Member ART Refill model developed from a community ART refill group model that was already being implemented. Clinically stable children over 2 years old can now join their family group. Every 3 months, one family representative collects ART refills for all stable ART family members and distributes these at home. Children between 2 and 5 years old are required to attend every time with their family representative for a clinical consultation. When children are at least 5 years of age and on adult ARV dosing, they can attend every second visit, 6 monthly, for clinical consultation. To conclude, let's reflect upon the content shared in this module from your personal and professional perspectives. Take a few minutes to ponder the following questions. In what ways can we proactively improve identification of HIV-infected children? Which infants and children are at an elevated risk of acquiring HIV infection? What do we mean by age-appropriate HIV testing? When should ART be initiated in HIV-positive infants and children? What is infant ARV prophylaxis and why is it important? In your country, what is the guidance on infant feeding in the context of HIV transmission risk? This concludes the training module on diagnosis and care of children living with HIV. Thank you for your participation. You may now exit the presentation.